Hi, my name is Dan Joyce. I'm a urologic oncologist at Vanderbilt University Medical Center, and I have the distinct pleasure of being joined today by a good friend, colleague, and mentor, Dr. Sam Chang. Sam, thanks so much for being here and chatting with me.
Oh, dear Dr. Joyce, Dan, thank you. It's a pleasure to have the opportunity to work with you and learn from you. And so looking forward to this conversation.
So we're going to talk a little bit about small renal masses, and it's an area that there's a lot of exciting things happening, especially with diagnostics. I just want to start by setting the stage. What is your approach to, say, a 3 centimeter renal mass, solid renal mass coming into your clinic, who you're excited about operating on?
Well, first of all, the vast majority of those seem to go to you. So I guess that's the first point. But, if you look at the AUA guidelines for small renal masses, we have the initial discussion of surveillance versus biopsy of some type versus going ahead and proceeding with some type of therapy, be it a thermoablative or surgical intervention. And now, for certain individuals, we even think about SBRT or radiation techniques. And in all honesty, all those three kind of interventions, diagnostic leaps, or therapies really dependent upon not only the characteristics of the tumor, but also kind of the patient characteristics. So, if we think about the different diagnostic modalities, the vast majority will have a renal ultrasound and or CT scan. And the question is, then once we have that, are there certain things that we do that may be actually, in fact, more beneficial in terms of kind of teasing things out? And it depends upon that kind of initial finding that helps me decide, okay, where do we need to go next?
And so, is there a certain situation where you're more likely to say they come in with a CT renal mass protocol and you say, you know what, an MRI might help us here, or maybe a renal ultrasound might help us here? Who are those patients, and when are you thinking about we might need additional imaging in order to help make a decision?
Yeah, I think we all face those mixed density, um, cystic versus solid, a combination thereof, and or those that are minimally enhancing, that we think, boy, this is really something that we don't need to necessarily worry about. Obviously, we looked at characteristics separate from enhancement. We also look at kind of borders, size, location, all those types of things. But I think when you look at all those modalities, a solid enhancing mass, we pretty much are tell folks up front, look, I know it's a smaller lesion, but you have a 3 out of 4, 80% chance, 85% chance that this is a malignancy early on. And so when you look at the characteristics, it then helps you decide, gosh, what do we do next? Now, to be honest, this is something that we've talked about, Dan. I have not ordered a sestamibi scan, I think, in the past couple of years. And I don't know if you ever order them, but I haven't found them quite helpful enough in terms of the findings are fairly good, mid 80s or so. But these tend to help differentiate clear cell versus oncocytomas. Okay, great, but also can hide some of the chromophobes that may in fact be more dangerous. May also be helpful in these hybrid oncocytic type cystic chromophobe type lesions that also could be more dangerous than the oncocytomas. So I personally haven't found that helpful. I don't know how often you use it.
Hardly ever. And I completely agree. I think not being able to differentiate between the oncocytoma and the chromophobe limits its use a little bit. And I agree also. I think, for the most patients who are good operative candidates who have a small renal mass, 3 centimeters or greater, that kind of looks like a duck, quacks like a duck, I'm not really pursuing much more there. I'm kind of
Yep.
proceeding with the interventions. I'll discuss biopsy, like you said, per the AUA guidelines. But honestly, the vast majority of those patients aren't really even interested in that. They see it, they're okay with that 20% risk of it not being something. And I certainly that's important information for them to know, especially if we're cutting that out. But they often are pretty happy even when they get a benign path after a partial nephrectomy because they're done with it and they can feel good about it.
No, I think that's actually very much similar to my thinking. These modalities, and I'll talk about ultrasound in a second, but these modalities, many times I'll do an additional test, in all honesty, to try to avoid therapy in those individuals that we we really feel the overall picture doesn't really lend themselves to doing a treatment. Those patients with more comorbidities or limited renal function, those are individuals where, in all honesty, we're looking for a rationale, not necessarily an excuse, but some type of evidentiary support to say we shouldn't proceed with any type of ablative or surgical therapy. That's why, while I'll do many of these tests, okay, I think it's safe to follow it, reassures the patient, it reassures the caregiver. The ultrasound, obviously, it's helpful for cystic versus solid, but I'll also use it many times for helping me with preoperative planning, especially in those lesions that may be more central or deeper or not so clear. And that I like to know before I'm in the operating room that an ultrasound kind of helps identify this lesion and I can see what it looks like. So it's a little perhaps old school, but I like to have that kind of roadmap prior to anything in the operating room because I don't want to be totally surprised because we've all been in that situation where where's the tumor? And I like to have as much preparation before and as I can.
Yeah, it's a great point, especially in your endophytic, tough to find tumors. I think it can be really, really helpful. So, you know, you're touching on kind of these areas of, okay, now we're seeing the patient who isn't really the person we're excited about operating on. Tough call. Do we pull a trigger on something else? Or maybe it's in a bad location, doesn't really look amenable to cryo. SBRT is tough. The duodenum's right there.
Yes.
What are you doing in those situations? Are you pulling the trigger on biopsy right now? Are you just watching with imaging and looking at growth? What's your approach?
I mean, I think that's a great question. I think there's undoubtedly, I personally have increased use of biopsy, but in all honesty, again, in that situation to help guide therapy, honestly, more likely to say it's safe not to do therapy. In all honesty, though, you could probably get away with surveillance. I use biopsy in that situation where doing a therapy may in some way significantly negatively impact the patient. So I want to know up front, gosh, I really should do this. The solitary kidney, the poor renal function, tough location where a partial may not be able to be performed and we're going to have to do radical, etc. I want to know that before I actually start this endeavor that may be negatively impacting the patient, that it's something that we really need to pursue. Because in that case, if that patient does have a chromophobe or an alkylacitic need, something along those lines, I'm going to do surveillance. I'm going to do everything I can to try to avoid injury to those patients. You know, I think down the line with other kind of imaging modalities, like the girentuximab and focusing on targets like CA9 and other kind of more, promising tests. I don't know. You've told me a little bit about KIM as a serum marker. I think those things, just as we've learned more and more about different things such as PSMA imaging for prostate cancer, I think we're going to get to the point where we're going to have a better idea with some type of biomarker, not only kind of the overall prognostic concern of even these small tumors, but also prediction-wise in terms of what therapies may or may not be helpful.
I totally agree. I think individualized medicine has been a buzz term for a long time that we have yet to really see come to fruition the way we want it to. But we're in an age now where technology is really rapidly advancing. And, you know, we haven't even touched on what is AI going to do in evaluation of imaging and in
Oh my
addition
gosh.
to genomics and how that's going to inform, you know, I don't think it's going to be one thing that's directing our treatment. It's going to be a combination of things using technology that really is going to be able to individualize, maybe for the first time in since the beginning of discussing this topic,
Yeah,
to really make a
you're right,
difference.
Dan. To be honest, I've thought about this in the past, but now just talking to you, I know I know individuals, colleagues that you worked with at Mayo have been looking and have been meticulously looking at multiple hundreds and hundreds, and now with AI, thousands, hundreds of thousands of images corresponding it with pathology, and then being able then to put that into a large kind of AI type model. And you understand that with that number of iterations, the more you learn, the more it learns. it's going to be pretty predictive of what's actually going to be found at the time of surgical intervention, and you can see that actually probably replacing biopsy.
Hmm.
Uh, will it have that ability to predict upfront response to immunotherapy? Like perhaps KIM shows some benefit with that. Will it be able to help us overall prognosis wise? Maybe. But obviously, in 5 years, things could be totally, totally different from what they are now.